This is a video about assessment of rectal polyps using a Fujifilm EG-760Z gastroscope. And this is quite an interesting polyp. So you see right now that we're right at the verge dentate line here. And if we switch to a detection mode, it becomes obvious that at the bottom left of the image versus the top right of the image, something's different. And if we switch to a characterization mode like BLI and we increase the magnification slightly, we really clearly see the difference between the squamous mucosa now at the bottom left, the polyp in the center of the image, and the normal squamous mucosa up here at the top, and then the squamo-columnar junction or the dentate line at the top, which is relatively normal looking, although here maybe there's something else going on here, but the main event is down the bottom. Okay. And then you cannot get much of an idea about the extent of any rectal polyp that's on the dentate line without retroflexion, I would say. So really you have to be able to retroflex properly to assess it, and that is not so difficult to do normally. The multiple other videos that we have made to assess that, but then let's just take an overview. And let's not do it in a characterization mode, but let's do it first in a detection mode, like high definition white light in this case. And you might think, well, there's nothing there. And actually, to be honest, it's the thing on the left, not the thing on the right, that draws your eye the most. The thing on the left is a scar. So this here, a little bit the peristalsis, but this is quite a significant scar here. So the patient has had radiotherapy for a significant rectal cancer before. That is this scar here. And then on the right side you have the either remnant or recurrent lesion on the right. And this looks just like a standard colorectal polyp. How can we characterize this better? Well, we can see that if we had been using a detection mode, would we have seen that better? Not necessarily bringing the scar out more, but it does probably highlight the polyp tissue better than white light in LCI. But of course the gold is in the characterization mode here. So from afar there's no issue with that polyp. Our structure of first blink, then go closer. The blink is that this is a relatively homogeneous thing, no blink features, and when you go up to it and you go slowly across the surface, spending some time but not too much on the whole thing, so as not to bias yourself. And remember, we saw the other margin from the forward view. We don't see any evidence of irregularity here, and to confirm that, if you want to, we can look at the microstructure and just gently go piece by piece. I mean, you need to be a patient person to properly characterize polyps, but we don't see irregularity here. We're not seeing any irregularity here. So it doesn't look like this is recurrent cancer. It looks like this is dysplasia. And what type of dysplasia is this? Very difficult to characterize this endoscopically, I would say. But here you can see in retroflexion, we're up on the dentate line again, and you can see the extent of the polyp here. So I think a benign recurrent dysplastic lesion, not cancer, on the scar of previous chemoradiotherapy. And it's totally flat, so I think if there is no chance of buried disease here. So for me, this is a benign lesion, but choice of technique, well, we'll just come on to that. There's one other thing, and that is the margins of this. So I think people can be burned by this sort of lesion with the margins not being clear. So if you go to the scar, it's quite easy to see, I would say, and then just so we have the water jet down a bit maybe. Is it on maximum? Always turn your water jet down. Yeah, I don't know, it's probably all right. Maybe it's too low now, a little bit more. So people are often burned by the other margin, but this is actually very, very subtle. So if you use water here and you use the cap to compress it, look at the subtlety of that margin. So the polyp's really growing onto the scar, and you really need to be careful of that margin, I would say, and probably apply actually some sort of thermal treatment to that margin. And water is really helping with that view. And I think we can anyway do that despite what we do. But then this margin is also super subtle. Okay, so here we have, let's just find a margin. We've got some water in, some water out. So if you have this situation ever in endoscopy, just put more water in, I think, as long as it's not a dangerous situation for the patient. And then the question is, where does the polyp end here? And it's not so easy because you have the microvascular change that comes along with radiotherapy as well. But actually I would argue that at the bottom of the endoscopic image now, where the line is of the screen, is where I think the margin of the polyp is. And if we just zoom out again, so we can see that there is a line there. It is relatively subtle, and you can see it as we come back around here. The water beautifully demonstrates it, but you can tell, or you can probably appreciate how difficult that is in the radiotherapy change situation. So you need to be careful. And yeah, therefore you need to be doing this sort of thing all the time if you're going to tackle a lesion like this. So I hope you found that interesting. I think we can summarize. This is a dysplastic lesion, and actually if you want to call it morphologically, it's a Paris 2A LMPCP without evidence of invasive cancer at the site of previous radiotherapy. And the choice of technique we didn't discuss, but this is a nice overview image. The choice of technique will be ESD because of the difficulty associated with the fibrosis of this part. I think you could perform EMR for this, but it would not ensure that left margin, and it would have to be piecemeal and destructive. And this is a young patient, so in this case, I think we can do ESD. But EMR is not wrong here. I think if you want to clear this lesion, you could do it with EMR, definitely. All right, thanks so much for watching.